Gaby, last time we left off, we spoke a lot about endometriosis, but we left off with a message. It's a complicated disease, but it can be as simple as you simplify it, right? Listen to your patient, refer them early on for surgical intervention, and that very importantly, like certain stages of the woman's life won't cure the disease. Pregnancy won't cure it. Actually, as it might slow it down or put it at a little pause, but then it can come back with vengeance later on. But a bigger stage that I wanted to talk to you about is menopause and perimenopause. It's a big stage, big change in the woman's life. But those with endometriosis don't stop having endometriosis when they get to menopause.
But I cannot tell you how damaging to a lot of patients is the concept that go through it, you still have a couple of years and you get to menopause and all your problems are resolved. I'm gonna throw in a few statistical facts so patients can understand a little bit more about menopause and how impactful, especially for patients with endometriosis. Do you know that there is a 7-fold increase that patients with endometriosis have menopause, are pushed to menopause, especially surgical menopause? Natural menopause, usually patients with endometriosis have 2 years shorter than the normal time of menopause. So imagine if the normal time is 52, usually they have 2 years shorter. They have a 3 times an increased chance of having premature ovarian insufficiency, or the ovary naturally stop functioning before the age of 40. So menopause is a common problem, especially with patients with endometriosis, because it is done surgically, unfortunately, for many patients. And now we have to deal with the consequences of menopause on patients who have endometriosis or active endometriosis. That leads to far more challenges. And I know, guys, you do a lot of mental health and impact on mental health. So imagine an undiagnosed, difficult disease to be diagnosed after menopause, how much it can take a toll on the patients.
Absolutely, yeah. I mean, other than the disease itself, the decline in hormones, the change in the gut microbiome. Again, we have to think about, these, perimenopausal, menopausal women. A lot of them have a lot of stressful lives. They have careers, they have kids that, they have to take care of their kids, they have to take care of their parents. So they're in the middle. Adding the decline in estrogen, which is a super important hormone that we find everywhere in the body, from the brain to like the muscles to the bones. So all this plays a role. And again, when I remember when I was a resident, I had a close family member that had a bowel obstruction. And of course, we thought it's, malignancy. Turned out to be endometriosis. I did not believe it. I was like, there's something wrong. I was the chief resident, I thought like I knew better. It's like, how come she's menopaused? How did she have endometriosis on the bowel causing obstruction? So this is proof that endo can still progress in menopause. And yes, I cannot emphasize the importance of mental health.
11% of patients with deeply infiltrative endometriosis progress their disease. It's not only stable or it regresses, progress their disease after menopause.
It's amazing. So, and we're talking about, the gut, the mental health, and people should know that endometriosis is not a hormonal problem only. It's an inflammatory, systemic, component. But definitely hormones do play a role. I mean, you agree that hormones and, estrogen, progesterone, the balance does play a role, but it's not everything.
Of course. Now, obviously, these women, when do they get to perimenopause and menopause, they have to deal with 2 existing problems at the same time. They're dealing with their debilitating pain if it's not taken care of, plus all the problems that come along with the declining estrogen, testosterone, progesterone. Somebody is already having pain and all the associated anxiety that comes with the pain, and you put on top of it menopause and the irritability and the lack of sleep and the change in their gut microbiome, et cetera, et cetera. So you're having 2 combined problems at the same time. But one obviously doesn't stop, as you mentioned, Gaby. So we have to tackle them both at the same time. You cannot just ignore endo and treat menopause or vice versa. You have to treat both.
But I had the patient similarly. She asked me, yes, I had endo when I was younger. Now I'm in the perimenopause. can I take hormones or hormone replacement or hormone optimization?
Before
what
we
do they-
get to the hormones, because I think this is an extreme topic that needs a lot of attention, and then a lot of patients ask us. I just want to point one thing that a lot of physicians still believe until today that the ovaries stop producing estrogen, that means endometriosis will die. And this is the biggest misconception. First, because, endometriosis tissue have aromatase that transforms the testosterone that is produced by the adrenal glands and by the ovaries as well to a weaker form of estrogen, estrone. Endometriosis tissue have the 17 beta hydroxylase type 1 that transforms the estrone to estradiol. So you have an area where you have a higher concentration of estrogen despite the ovary not doing anything. In addition to that, the peripheral fatty tissue contributes to the creation of estrone. So now the ovary, beyond their function, endometriosis tissue can carry on the production and the concentration of estrogen, and that continues to produce a variety of symptoms, including inflammation. And that's what leads us to hormonal replacement. That you prescribe a lot of those, but what do we do with a patient with endometriosis and hot flashes?
Right. I mean, you cannot negate someone who needs HRT for all the benefits from head to toe, and just because they have endometriosis. No, you have to tackle their endometriosis and give them the benefit of HRT, because otherwise you would leave them in debilitating pain that's not gonna stop. Plus, they're gonna have heart disease, bone loss, weak muscles, etc., vaginal dryness, urinary infections, etc. So the short answer is that these patients should have estrogen replacement, but it should be done under caution and under guidance, keeping in mind that they've had endometriosis, whether they've had it resected or not. That should be the biggest.
One thing you could also do, I mean, it's of course not like standard of care, right? But you can do a test called the Dutch test, which is a dried urine test where you can know the metabolites of your estrogen. And some of the metabolites are associated with proliferative disease like endometriosis, hyperplasia. So depending on that patient, where she metabolizes her estrogen and to which pathway, you can maybe have more caution in certain patients versus others. But yes, again, you should not negate women HRT because of just the history of endometriosis. But the question to you, does it, if we do that, are we gonna exacerbate her endometriosis or not? That's
Actually, like if we go back, most of the patient, like around 4% of postmenopausal patients have endometriosis. But most of those that show symptoms of endometriosis after menopause are on HRT. So HRT is a big risk factor for the recurrence of the disease or the promoted that the disease that was not removed that will continue to grow and causes problems. But what we realized that even if patient had a history of endometriosis and they have a hysterectomy and oophorectomy, usually we prefer to give them combined hormone replacement therapy, estrogen and progesterone, that was shown to exacerbate less the endometriosis. Or we can give them alternative in some countries like tibolone is approved for postmenopausal, some alternative that would not create a high estrogen state or can promote the regrowth or recurrence of endometriosis. But I believe in patients where you don't have option, I think targeting the disease by a proper excision and removal of the disease might provide not only decrease of inflammation, not only a benefit improving the pain, but also giving them more options to utilize hormonal replacement therapy in a safer way.
Exactly.
Because the best treatment for menopause is hormone replacement.
Yes.
Obviously for somebody who can receive estrogen. There's no doubt that it's, gives you the best benefit overall for your skin, your brain, your heart, your bones, your reproductive system health. So one should make sure that they get their endo treated, taken care of, because the consequences of not getting hormone replacement are probably gonna, double or triple.
Yes. And plus, like a lot of the patients are placed on GnRH agonist Lupron that will kill the bone density. And now we have an inflammatory disease, an ongoing natural bone density loss, and you cannot even prescribe them something to maintain their bone density. So the
I think this is
risks
the
are
misconcept that
accentuated.
when they give them GnRH agonists to stop them, make them into a menopause, stage. This is the misconception that endo is only a hormonal problem. So it's not only a hormonal problem, it's an inflammatory problem. We have to target many things. We have to target their, stress levels, their gut, give them, things for inflammation, decrease their toxin load, strengthen their liver detoxification pathway. So there's
Sexual function.
yeah,
Like
this
you
is like,
cannot give
and their
testosterone
pelvis,
even
yeah,
replacement.
yeah.
Because if they have all those aromatase, they're going to transform it to an estrogen.
Exactly.
So what happens, it was shown now without doubt that endometriosis postmenopause affect the sexual function of patients. Without doubt, and this is 2025 recent study, a meta-analysis done on a large number of patients, their sexual function is tremendously affected in patients with endometriosis, and it's way lower. So now you're handcuffed. So I think every treatment should start with a proper targeting of the disease, of the generator of all the problems, and then we can manage with more options the other ancillary stuff.
It is mind-blowing that if you imagine someone's journey that has suffered with endometriosis for years to go through perimenopause and menopause and be denied the treatment because it might flare up their disease, just go through the mind of that person going through that pain journey into the consequences of menopause and not getting the appropriate treatment for both diseases.
And add to it, some of them have infertility issues
Yes,
and
yes,
had
Yeah.
went through fertility journey, and then on top of this, all these so it's not right, like you said.
I wanna go back to the dried urine test for hormones that you were talking about. These can give a lot of insights of the detoxification pathways.
Yeah.
Obviously, it would tell you if somebody's favoring certain pathway or the other, and then you would support the favorable pathway with certain diets, supplements, etc., in order for them to go through the most favorable pathway. Even if they're on HRT, you would want to make sure that because
Of course.
anything you give to a patient, they'll end up getting that metabolized in the liver,
Yeah.
and those metabolites can circle back and go into the system. So we want to make sure that we're giving them back the appropriate support for that HRT, or even if somebody's not on HRT.
Exactly.
No, it's like when we start looking at a patient as a whole rather than as a symptom or as a simple disease, that we look from it from the perspective of the genital or the pelvic system, where it affects multiple things. And I've seen patients, even though what makes it even more challenging that now after menopause they don't have a period. So now it's confusing for them, even the symptoms. They don't know when they come. And then now that puts more challenges and leads to a fragmented care with multiple specialists tackling different things, where the disease is a continuation of a premenopausal disease that nobody did. And whenever you have scar tissue, like you talk about the patient with obstruction, the scar tissue does not go with menopause. If it is entrapping a nerve or if it's causing a bowel problem.
Speaking of scar tissue, like I came across a couple of anecdotal or maybe treatments or things that I don't know how evidence-based, but some people recommend women to take enzymes, certain type of enzymes, to kind of break down these adhesions.
If it might work, it's not instantaneous.
Yeah, I know, exactly.
It's years.
You think they're already in the scar stage. I don't know what can dissolve those scars. So I don't know if you know anything about those treatments.
I think prevention is the best way. And considering you have the ongoing inflammation, so you have the generator of the scar tissue always present. So even if you give a treatment for something ongoing.
What are things we can tell, let's say, young teenagers when they first start getting periods? I know there's definitely genetic component, but what are things they can do to prevent developing endometriosis? In the past, you used to say, oh, this was probably retrograde menstruation. But, these are all myths.
Yes.
But what can we tell, let's say, a 12, 13-year-old who just started having periods, what can she do to prevent this disease from progressing or from even happening?
I think preventing is a big word. It's extremely hard because we don't know the precise causes of the disease, and plus we cannot change genetics so far. Knowledge is power when you have a chronic disease. So when patients know what they have, they are more apt to work with the physician with the right strategy to minimize the impact of the disease on their whole body. But preventing is hard to say. Decreasing the chances or the impact of the symptoms, the impact of the gaslighting, the early diagnosis, the impact on fertility is key. This is what we can prevent. We can prevent further damage. We cannot prevent the creation of the disease so far. We cannot change the gene of a patient, and we don't know precisely every single reason for every single patient that produces endometriosis. Beyond the super dumb theories like retrograde menstruation, which does not explain an archaic theory that has no value in the modern
I still believed in
science.
it.
It's sad that
Until I met you.
a lot of patients are told this.
Yeah.
Some patients are told that, it can be contagious.
Oh,
It can be sexually transmitted, or,
a lot of myth. And I feel like the worst thing that happens to patients with endometriosis is the fragmented care they get, because everybody tries to treat one part of their symptoms that relates to their specialty. If you have diarrhea during the period, go to a GI. If you have headache, go to a neurologist. If you have
get pregnant, go to the OGYN. Yeah.
It's unbelievable.
Have you heard of like vaginal steaming, where they, get steam into the vagina to clean? And this is one of the things that also can, you find those on social media that they can, cure infections or cure endometriosis even by steaming. Steaming, yes. You can steam your clothes, but you can steam the vagina. Yeah, it's a practice. Many people do it.
Those practices, I think, in the absence of any evidence-based medicine, are harmful until proven otherwise.
Okay, so we have to
Because
warn,
the
don't
heat-
steam
The
your
heat
vagina.
will burn first the tissues, and the heat will kill the normal bacteria. So you have, in addition to the dysfunction of the microbiome created by a chronic inflammatory disease, we're adding an insult by steaming and killing the rest of the bacteria that could be beneficial potentially to the disease. So I think there are a lot of, alternative medicine or maybe practices that exist on social media or on the internet or on Google. I believe like some of them might have truth, but in the absence of medical evidence, we cannot recommend any of those to our patients. And we caution them from utilizing whatever they read, because that will lead only to disasters.
Yeah, I hope none of my patients are steaming anything.
Maybe we should ask them tomorrow.
I can imagine how many of those end up in the ER with
burns
with burns.
Yeah. And then the douching also, vaginal douching was also kind of the same idea, to over cleaning the area to change the flora, but again.
Okay, I want to talk about the combined mental problems or mental effect that happens from endo and perimenopause into menopause. By themselves, each problem can cause a huge mental burden on somebody. Putting them together, I can't even imagine the combined. It's not probably just 1 + 1 = 2 in that. It's probably 1 + 1 = 5, a synergistic effect. What shall we tell? How shall we, approach that aspect?
No, I think a lot of our patients are overwhelmed because they've been bombarded with multiple symptoms. Many times they go do labs, they go do tests, everything is negative. So they're gaslit by the multitude of symptoms, and they started believing that there's something wrong with themselves or they're trying to be sick. No, I think it's fragmenting the problem and simplifying it for a patient. First starts with believing them, trying to address the multitude of symptoms, because both menopause and endometriosis can create an impact on mental health. So I'm a surgeon. I can understand the impact, but I'm not qualified or nor I have the experience and expertise to treat mental health problem. So that's why a multimodal approach where you combine a mental health specialist, cognitive behavioral therapist, or psychologist with the endometriosis surgeon that manages the disease with
A
somebody who's
nutritionist.
experienced in hormonal replacement therapy, so we can communicate together what is the specific best approach for this patient and how can we manage the flare-up for endometriosis with the need of hormonal replacement therapy or supplementation in a comprehensive way rather than a fragmented care. I prescribe, deal with the symptoms, they come to me, I have those symptoms, but my doctor said I have to take those. So the communication is key. Listening to the patient, communicating with the different specialists, each in their area of expertise, creating a long-term strategy. We're dealing with a chronic disease. It's not like you give a Tylenol, pain goes away. No.
Yeah, and you mentioned something before about giving estrogen and progesterone, even if they had a hysterectomy. I think this is so important. Even with women without endometriosis, I think a lot of them are not given progesterone and they're only given estrogen, they're having trouble sleeping. So even if you had the hysterectomy, you must be on estrogen and progesterone. And of course, testosterone is a different thing, but of course, testosterone is big and so helpful. But maybe also with the endometriosis, what Youssef was talking about, the metabolism of, so also the route of how we give the HRT is important, whether it's going to be transdermal, pellets, oral, vaginal, so injection. So also maybe that, maybe in endo patients, maybe we should use transdermal more than oral. I really don't know. I have to look this up, but maybe also the route. That's why you said you have to have a specialist that has experience in treating women with endometriosis, because some women might have endo, they never knew, they got pregnant all this their life, and now they're menopause, and we don't know they have, and they were never diagnosed with endometriosis. So that's why I think someone with experience, with especially patients that had surgery or had endometriosis struggles, to seek a specialist with HRT.
And obviously, don't forget about the support. I'm not talking about just the day-to-day support with the supplements that they need to be on, the nutrition that they need to be on, their exercise,
restoring the microbiome.
Exactly. So all of these should go hand in hand. It's not just one thing that's going to work.
That's what we like to call it, a comprehensive approach to treating endometriosis. It's beyond the surgery. It's beyond one person treating the whole problem. It's a multitude of specialists and expertise gathered together to provide the patient the best route and the best quality of care to enable them to get back their quality of life. Because it's beyond, when we deal with different diseases like diseases that are directly creating an impact, like, for example, cancer. I hate to compare endometriosis with cancer, but with cancer, the studies, the outcomes. Patients are struggling between death and non-death. With endometriosis, the major impact on the quality of life is tremendous. If you know yourself you have cancer, you accept it that, the most likely probability, unfortunately, is I'm going to die or I can survive 10 years. But with endometriosis, this is something that goes along all your life with you. If we don't have a strategy for the patient to cope with everything and to improve their quality of life, it's more impactful than cancer.
I agree. I mean, now that you brought cancer up, endo patients are at increased risk of having ovarian cancer, right?
Yes.
And also women, as they get older, age by itself is a risk factor, getting into that menopause and post-menopause thing. So that should be given a special attention to. These patients should be followed up more closely if they've had an endometrioma on their ovary in the past. That should be followed up to make sure that, this is not just, you're in menopause now, let's forget about it. No, we should follow it up routinely, look at it, ultrasounds, maybe if there's some changes, get tumor markers, etc.
I completely agree. Even though, we don't want to scare patients with endometriosis, but unfortunately, they have a higher risk of ovarian cancer than the people who doesn't have endometriosis. So it's around 1% the chance. And then it's important, especially if patients are hormonal replacement therapy, because when we look back at the risk factor that progresses endometriosis to cancer is, for example, the presence of ovarian cyst. They keep watching, or they know about it and they don't watch it. The presence of the disease itself not dealt with, especially deeply infiltrative endometriosis, and patients who are on hormone replacement therapy. So that's why if you have an endometriosis cyst, even if it doesn't change for a year or two, that does not mean it's safe to keep it away. No, it should be followed usually every couple of years for the changes that malignant changes that can produce. The patient on hormone replacement therapy needs a very special care, because you cannot just let it go and say like, oh, it's not progressing. We have to look for signals or tumor markers or stuff in any change, morphological change in the appearance or the consistency of those cysts after menopause.
I'm gonna play a little bit the devil. You're talking about women on HRT as a risk factor, but remember, a lot of the studies out there, these HRTs were different than the HRTs today. They were synthetic HRT.
Right.
The dosages in each study was different. So again, we cannot extrapolate those studies.
Of course, I
Yeah,
agree
yeah,
with you, but it's an eye opener for
yeah,
us.
of
not
course.
to leave
Yes.
anything.
But this
even
is
though,
also, gives women hope that you
Yes.
can still be on
Right.
HRT even if you have
course,
endo,
you
because
should be.
today the dosages are different, the routes are different, and the compounds are different. They're
They should be on
they're bioidentical or body identical, they call them in the UK. And I think, like Youssef saying, they should be, of course, with caution, but yeah, we don't want to scare them.
Every decision,
Or don't let anyone scare you.
patients need to be informed to make any decision, while they can outweigh the risk and benefit of everything.
Yeah.
For us, our job is to clarify those, and for them is to choose. For us, our job is to be alert, to inform them appropriately about the risks, and then for them, it's to understand everything and at the same time follow up. It's not like we cannot do HRT even in patients with no endometriosis lightly, because they carry a set of risks, but those risks, with the right hand, with the right provider, with the right patient that follows up, are mitigated by our knowledge and the things that we can do as a prevention.
You mentioned endometriomas. Endometrioma, no matter what the size is, say 2 centimeters. That's not too small, not too big. And someone who has done having kids and approaching their early 40s, do you think we should take them out?
To be honest with you, endometriomas is a complex situation, because endometrioma could be a symptom of deeply infiltrative endometriosis. So many times we look at the endometriosis cyst as a cyst with a size, which is not the reality. The reality is bigger. The reality is, first, if we're going to target the pain, the symptoms, the impact on the surrounding tissue, and if we're going to target the inflammation created in the whole body. So I don't look at endometrioma as a cyst with a size. I look at it as a symptom of a larger disease. We need to see how much the disease is impacting patient, whether the patient wants surgery to remove the disease or keep it, and then how can we create a comprehensive strategy for the patient to understand when it's time to remove it, when it's time to follow up, when it's time to check back with the surgeon. So it's a far more complex than looking at a cyst of 1 centimeter or 2 centimeters.
The tip of the iceberg. Right?
It's a whole body disease. That's why we need to target the whole body, because sometimes patients with endometrioma don't have pain. They have a bowel dysfunction, they have severe inflammatory symptoms. We know nowadays thyroid is highly linked, TSH is highly linked to endometriosis. We know that the decreased AMH with endometriosis and increased FSH put patient at a higher chance of bone density loss. So these patients are at high risk for osteoporosis, osteopenia. So it's beyond the cyst. That's why endometriosis is a systemic disease. We should avoid looking at it as a pelvic disease or pain only, strictly.
So you're putting functional medicine into
Yes.
that, right? You're going back to the root. Yeah.
Interesting that you mentioned the link between the thyroid and endometriosis, which a lot of people probably, would think that they're two separate things. But talking about, exposures from food, et cetera, what are your thoughts on gluten, dairy, excessive caffeine or coffee?
It's like we go back, there are not specific for endometriosis, there's for every inflammatory disease. So for me, endometriosis is an inflammatory disease, but there are a lot of other diseases that are inflammatory. And I think an anti-inflammatory diet, low in gluten, low in sugar, that minimizes the insulin growth factor in your body, minimizes the inflammation, will be helpful in multiple things. But there is definitely, because whenever we have endometriosis, we have a major impact and an insult on the immune system. So you can see a lot of diseases express themselves. Like you see a patient with endometriosis with a multitude of diseases unrelated completely to the pelvis. Like thyroid, we see POTS, we see leaky guts, we see. So that's why I believe diet and anti-inflammatory measures that we take to minimize the inflammation in the whole body will be helpful for a multitude of diseases.
Because a lot of the diseases start in the gut, right?
I mean, we have nothing against bread and gluten, but the problem is that, the highly processed wheat that's been
genetically engineered,
And
fortified.
sprayed and
Exactly. So, you would see with people who eat ancient grain versus, regular wheat, the inflammation is less, with those who eat ancient grain. But obviously, if somebody who's allergic to gluten should not go experiment, But
Even though, but this is a very interesting thing. I've had a lot of patients. They can eat bread in certain countries. Like when they go to Europe, they say because it's highly regulated the way they process the wheat versus here where they bleach everything. So you see patients, they say I don't have any problem with gluten when I travel, only in certain areas or when I buy a certain kind of bread, I will have this problem.
Absolutely. So it's not only the gluten, it's the pesticides that are
Yes,
that get
Nutella.
into the grain and stick there. Even when you cook it, it's still released into our gut and causes the inflammation. Absolutely. Thank you.
Perfect.